Okay, it's started recording. I'm going to shift it up into slideshow if I can. And have to fix my little felt tip pen. And we're going to discuss adenoid tissue. And by the way, I'm Dr. Bill Wyatt, and I'm going to be covering some stuff here on things that we lecture on. And this subject here will be on adenoid tissue and its effect on the airway and facial development on children. It's actually has a tremendous effect on them. Here's a young lady that we'll discuss. She's got an unusually large adenoid tissue, and it's kind of blocking her airway and causing her to breathe through her mouth more than she really should. She's got a slight excess in vertical height, and the chin is kind of an open bite situation, and really you'd like the chin maybe to end up somewhere around here, and it's a little bit longer. The vertical height of the face is more than you would really desire to have on this case. And now we look at it from the frontal view, and probably if the chin were say about this length and these spaces were about like that, the face would be balanced and look better. So she's got a little excess vertical dimension of the face, and that's what we're going to try to treat and try to keep this from getting any larger if it's possible. So high angle cases are kind of hard to deal with. The first thing you want to get at is to get rid of the cause for the development of the high angle. I just don't believe people are born with the high angle gene that's going to make it high angle. You may be born with a thing that makes the high angle, and maybe your mother or one of your parents had that, and they had a long face too. We can't tell that, but I think that it develops afterwards. So here's the little girl. We had gone in and started the braces on her, and we'll look at the kind of got a deep dental bite in the anterior part of the mouth anyway, even though we've got an excess vertical height of the face. Now we'll look at the side view of the face. It's kind of an end-on molar relationship here, where you'd really like the lower molar to come out here somewhere, like and be like that, and have these teeth would be out pretty much with the upper anterior teeth. So we got a small class 2 problem along with this development like that. The other side of the mouth is similar, maybe a little better class 1. It's just a little further forward. You'd really like for it to be more out like that. So it's got a class 2 problem on the left side, not quite as bad as the right side of the mouth. Looking up above, we've got central, of course, it's out of place, and the lateral and deciduous lateral over here. We'll have to look at and then all of these are deciduous teeth. Now when you have somebody that's starting to get a problem from a functional standpoint, you want to start the case as early as you really can and correct all the functional things, the breathing and thumb sucking and adenoid tissue and tonsils and all the rest of these things that you can possibly correct as early. And then the orthodontics is much easier to do, and it's much easier to maintain if you get rid of the functional problems. The lower arch looks pretty normal at this point, except it's got a little closed bite situation. She's got pretty good spacing in there. Now when we come around and look at the cephalometrics of it, though, you can see the adenoid tissue starting up here, and it comes pretty close to, well, you got some airway, but not enough in here. So the girl kind of sits with her mouth open frequently, or if you just walk out of the room, or you just walk up and watch her sitting there, she's usually got her lips apart like this. Now when somebody sits and breathes through just a little part of the mouth up here, their blood oxygen level isn't quite as good as if they were sucking air through the nasal airway and creating a suction down here, and it goes in real fast, and the air then gets out into the lungs better, and they have a higher blood oxygen level if they're breathing through the nose than do if they breathe through the mouth. Now this also dries the mouth out, and you suck a lot of allergy bearing particles down into your lungs this way. I've had people, I had kids that were having lung problems, and once you got their airway opened and everything, and they were breathing properly, keeping their mouth closed, breathing through the nose, they got over that simply because your nose filters, and the turbinates and everything in here, running air through, filters it. It warms it up to body temperature. It also humidifies the air so that you don't pull air in here that's not humidified and dry your lungs out and different things. So there's a lot of just physical value to being able to breathe through the nose as breathing through the mouth. And your nose doesn't seem to dry out. I mean, your body keeps enough moisture in there to where you humidify the air going in there. So people are just better off if you can get them to breathe through the nose, and their teeth function better. If they're mouth breathers, they'll usually be putting the tongue in the wrong place. If I already got the mouth open, I can't say if they suck their thumbs more, but they may. And people who suck their thumbs don't tend to bite their teeth together, or if they're breathing through their mouth, they go ahead and swallow wrong without pressing their teeth together, and so consequently the upper teeth drop down further than they normally would, and these rise up a little bit more. And as a consequence, whatever these move together, let's say if it's 2 millimeters back here in the back, it may be 4 millimeters out here in the front, that you'll increase the vertical height of the face. And as your jaw pivots up here on the condyle, and as it opens this way, it swings back in this direction, so you'll look like your jaw's too short when the jaw might be a proper length if it were up to the point where it should be, and here it might look better. Now this looks like she's got a little shortness of the jaw to start with. So these are some things you take into consideration when you're looking at how you treat this case and everything. So we want to get rid of the problem in here, so we will try to send the young lady into an ENT guy and let him make the final decision. But we'd like to get rid of the adenoid tissue, and frequently, now I've not been able to see tonsils on the cephalometric very good. I can't really tell you that I can just show them in here, but I can open the mouth real good, and you can see the tonsils. If you look in somebody's mouth, they got 2 big tonsils down there, and they're almost touching each other, or if they are touching, that's a number 4 tonsil, and just a little space in there would be a number 3, and bigger space a number 2, and number 1 are normal. You've got the tonsils in there, and they've got plenty of space there. If you have large tonsillar tissue and it's blocking the airway, you want to get rid of it. Now it's hard to get an ENT guy to come in and do that, to realize that if you leave the tonsils and the adenoids alone and leave them alone long enough, then you're going to develop this long facial structure, and then it's to correct it. It's almost a dead cinch to do some surgery and maybe shorten the maxilla up here, or other operations that lower the vertical dimension of the face, and they're pretty severe operations. So get at these cases earlier and you can keep the face normal. But during orthodontics, it's very difficult to close the vertical height of the face. Now we can come in sometimes with screws and put rubber bands over the teeth or something and intrude the teeth. Now we wear headgears that pick up the teeth, pulling back this way, or if we pull up in this way. But it's very difficult to lower the vertical height of the face with a headgear. Your kids just won't wear them enough. Now we are going to use, I think, a occipital type headgear on this young lady, which pulls from over on the occipital bone. So we'll go through and discuss that a little further down the line. Now looking at the case, you can see we had one permanent lateral in, the other one was kind of stuck off to the side. This lateral was kind of going way off here and running into the deciduous cuspid over on this side, and we need to kind of get that straightened out. So we'll need to put some in here and put some brackets on these. We'll bring these down, bring this tooth in correct, and we'll try to take care of the functional problem on this child. So here we have gone in and put what we call a 2x4 deal. We band the 6-year molars back here, and I use a lot of deciduous teeth if they're available in the mouth. So we bracketed this second deciduous molar here, and then run an arch wire in and band these teeth and start pulling them back in line. Now on the bottom, this young lady had a tongue thrust problem too, so we had the 6-year molars banded, and I've also bracketed the second deciduous molars, and then we came out and put bands on these lower front teeth and put these little fingers on the bottom that we tend to irritate the tongue when they do their tongue thrust, and this is the most effective way I've ever found of stopping tongue thrust. So we got tongue thrust problem, which is associated with the airway problem too. So you get all these things tied together in here. So here you can see now we've got the 4 anterior teeth lined up, the upper anterior teeth lined up, the bottom was lined up, and we have these little fingers here to irritate the tongue if it goes in there. Now that sounds kind of cruel in some respects, but I've put these on adults. I mean, you have adults that are tongue thrusters, and I have a medical doctor once, and I said, okay, we're going to put these on there, and it catches your tongue and it irritates it, and you'll stick it in there 2 or 3 times. And I asked him after a few weeks, we had him back and checking this thing, and he said, that's exactly right. I went up there and hit those little prongs about a couple of times, and my tongue just learned to stay away. I mean, it wouldn't go back up there. And you leave these on for several months. I like to go about, maybe 7 or 8 months with them in there. And by that time, the tongue is so used to not going up there that it tends to stay back, and you can break this habit on somebody. But to do it by somebody just learning how to put their tongue and practicing, I've had very little success over the years breaking this, but I've had many people that we've broken this habit on, and we're going to discuss that further on tongue problems. But anyway, we put that on this young lady, and this is the Panorex throughout the treatment we have everybody close their teeth together when we do the panoramic, so you can see where the molar relationship. You see that this is class 1 here and class 1 back in this area, and so this is lined up good, though we've still got some deciduous teeth to come in up above and maybe one down here on the bottom. But we have it class 2 problem pretty well whipped early on in the treatment. Now we come over, I'll show you this in the mouth. We were looking at the x-rays, we went all the way through, but now we've just caught this tooth right here, you see, and we'll pull it in and slide it over and correct that and get this all laid down. We've got a closed bite situation in here, so we'll need to open this bite, and this will need to come up some right here. You can put some reverse curve in these wires and do light wires like that. Now if it's real deep, we'll put that an intruding wire back here and raise it up from there. We'll get into that. There's a whole thing on intruding arch wires. Now if you look, this is a wildcat wire. It has no effect on leveling the bite. We're just lining the teeth up in here, but we put these tongue thrusts, we put bands on those teeth. Let's get over here to a picture where we can show that a little better. Now we're going to pull this together on the upper and line this up good, and we've got a round arch wire in the upper now, so it's now here is the little flexible wire. It's hard to deal with this thing in a long span, and it's good. You've got some anchorage on these deciduous teeth, and we don't have any problem putting brackets on deciduous teeth. They're going to be there for a good long while. And if I had problems with it, I'd put a bracket maybe on the first deciduous molar. And we've made these little bands with these hooks on them. These hooks are made out of 030 wire, and it's spot welded to the band once we fitted the band, and then we come in and flow solder over that spot weld, so that wire is really attached to these bands, so they're not very likely to break it off and swallow one of these hooks. But if they do, usually it'll go right on through. I've never had one hang up on the stomach or gut anywhere, but I've had one or two break out over 45 or more years of using this right here. So anyway, this is the setup for helping the tongues break the tongue thrust, along with correcting the airway by getting the adenoid tissue out. Alright, in addition to that, to help lower this down, we're wearing an occipital headgear, which we're pulling up and back on it, and you can cut the bar of this and regulate where you want the pressure. You can put all your pressure on your upper anteriors if you just make these little hooks right up here close to the anterior part of the mouth. You know, it'll just pick up the front part. So if your maxilla is like this, you can pick this part up, or you can cut those bars right in here and pick the whole thing up, or you can raise the molars up by where you attached the where you make the hook that you're going to hook this strap into. See, I'll try to explain that a little better later on here. Now you can tell we have this hook about around the second bicuspid area, something like that, in which we're pulling up. So we're pulling the anterior part of the mouth up. Now these are real effective when you're wearing class 2 elastics, which tend to drop the anterior teeth and give you a more gummy smile, and we wear this that holds the anterior teeth up while you're backing it up with the class 2 elastics. So the headgear is a excellent tool, and people condemn them and everything, but headgears do a wonderful job. It's just getting people to wear them, and a lot of guys advertise, we never use headgear and all this kind of mess, but you can't do the best orthodontics without using them sometimes. Now, we use them as little as we can get by with sometimes. Now, this is a kind of a blurred picture on where we have the headgear. It's in the 6-year molars, and we have a little tongue that a little bar that goes under here. Excuse me. I guess we'll have to edit that spot out of this thing. And the headgear is caught right, you catch it right between the upper centrals here. We'll discuss that more when we get to headgear. Now, looking at it from underneath, you can see this. We buy them with these little parts in them, and you cut that or bend it so it fits between the centrals. And now your other's plugged in back here. Now, if these bars, I probably can't pull it out, but if you're pulling up from here, then it'll put the weight more in this area right here. Or if you want to just raise the anterior, you can cut your hooks and hook it right out in this area, you see, where you're not very far from the centrals, and it'll tend to raise this area. Or you can run the bar back further and catch there and raise up the molar area of the mouth. It's a marvelous tool, really, when you're using class 2 elastics and things to do that. So we use occipital headgears quite frequently. Now the upper anterior is lined up a little bit. I should have brought this tooth up a little more, but this is the first phase, and we're not through with the case yet, but really I should have brought this tooth up a little bit more and get this lined up better across here. Now, let's see. Now we take her out of this and put her in a retainer, and we're going to hold this class 1 position, and we put a bite plate on this retainer which will keep these lower anteriors from closing up any further and keep her biting on this. And now we'll see, when she gets all these teeth in, we'll come back and evaluate this case and see if we need to come back and do some further orthodontics. Now our midline is not exactly on, so we're either got some two-side discrepancy, or we don't have as good a class 2 correction over here. In other words, we might need this brought further forward to move that midline over to that point. So we'll have that to do in the second phase of the treatment. So looking at it over here, we're fairly good, but then these are deciduous teeth. This is a permanent bicuspid. Now she's got all of her lower teeth in and got a bunch of baby teeth up here to go, so this is kind of an odd way of developing the teeth. So this side here will need to be corrected a little more class 2 correction than the other side, possibly. Here, let me go back and look. Now this side, yeah, we have a better class 1. You see that molar's out in front down here quite a bit, and so this is better class 1 over on the left side, and the midline kind of shows that too. And we'll have to evaluate it once we get all these teeth in. Now this is still a deciduous molar right here. It'll go, and this will come even further. So we may have a problem. You have to pull back. You could feasibly have to have a little class 3 correction, or we might have midline, various things that we would use in the second phase of treatment. Alright, down on the bottom, we've got all the permanent teeth coming through here, and we've taken all this off now, but we've got a deciduous molar here, and it'll be about that much longer than a bicuspid will fit in this area, and we'll have this much space. Now this either comes forward or this will go backwards to some extent to close that up, and as your second molars come in, they push on that also. Now up above, for some reason or another, this young lady's still got all three of these and all three of these. They've got to come out. So we don't know what it'll look like when they get in, and we'll have to come back and do a second phase of the orthodontics. I'm going to go into another case that had enlarged adenoid tissue, and it's really created a terrific deformity in the face. Now, in addition to the large adenoids, the guy had a thumb sucking habit and breathing problems and all this. And if you look at the face, this is after we had been in treatment a little bit. I think when I got these, it's not really as opened up as much as you would think. But when you look at the models here in just a minute, see, this is after we had brought the teeth down. I don't have the first pictures on this guy. Now, he was using the occipital headgear. It looked like we've got it cut pretty far to the back, so it'll be the hook, you see, of this wire. So it's pulling up from here, or you could shorten that and it would pull more straight up, and if you short out right out here, it'd just be pulling up on the anterior teeth right in there. This is still a good instrument to use. Alright, here are his models. These are earlier in treatment, and the guy comes in with a tremendous open bite problem. This angle of this picture is kind of enhances the open bite problem, and you can tell the thumb is sucking on something going through there, and then the adenoid tissue was having a real detrimental effect, and so we had too much vertical dimension of the face, and so we want to close this facial height down. We want to reduce this in our treatment. So one way to do it is, well, there's two things that we're going to do here. We're going to try to get him functioning right. We're going to try to work on the adenoid tissue. Then we can reduce the number of teeth on this case, but we don't want to flatten his face out too much. So we go to the back of the mouth, or just in front of the 6-year molars, and we take out the deciduous teeth. As these come up, you can take them all at one time. If you really, and we used to do that, we'd take the deciduous tooth and cut through the top of the bicuspid and stick a spoon in there and just slide it out through the hole, or you can let them come down a little bit or come up a little as the bottom would be, and take the permanent ones out a little later on down the line. We might send them to an oral surgeon now to do that. And so we're going to try to elevate these teeth, you see, and bring these down part of the way, but pick these up part of the way, and that will reduce the vertical height of the face and help us close this down and give him a better vertical. Now on the other side of the mouth, we did the same thing. We took out the second bias, permanent second bias, and the deciduous second molars in treating this case to help lower the vertical. And we correct the function, and then we wore an occipital headgear that was picking this part up too. So we've got three things trying to lower the vertical dimension of this young man's face. Now here we also wanted to expand it, so if we expand the palate and bring the teeth, roots and everything out, we're going to open the airway up here, and that's going to help another way. In other words, we get rid of the adenoid tissue. You get a mouth breather a lot of times and they don't press in here with their tongue, and you'll have a little narrow palate, and so you want to widen this all out and bring the roots of the teeth out, not just the crowns. Now these teeth are leaning already, so we're going to have to put some buccal root torque on them to bring the roots of these teeth out, so we'll get an increase in the airway up above. Whoops. I don't know what I've done. Discard. Okay. Get rid of those things. Alright, now get back on the track here. Okay, on the lower we had some other problems that we had to address. It's very rare you get a case that just has one problem. Alright, we've lost a deciduous molar over here. I'm going to have to go back and excuse me, I've got to go back to and develop this pen. Alright, we've lost the deciduous cuspid over on this side of the mouth, so our midline is shifted in that direction, so we got a little problem there. And we have a lateral and a central that are fused together over here, so we're going to have to deal with that as one tooth. Now thank goodness they are both lined up in a nice smooth line over here, so we can bring this tooth out, you see, and straighten it out and straighten that one a little bit and get these teeth in a nice straight line, and then bring them all over in this direction to get them in the center. Now again, we're taking the deciduous second molars out, and then we're going to go down and take out the permanent bicuspid underneath there. So we're reducing the tooth structure before the second molars come in, and we'll put more pressure on the 6-year molar, and these teeth will go in the meantime, so we can lower the vertical dimension of this guy's face. We're doing about 3 or 4 things here. We're opening the airway, we're correcting the adenoid problem, we're correcting the thumb sucking problem that he's got, and we're reducing teeth. So you put more load on fewer teeth and you can get them to depress to some extent. Now, here's the guy's face. This is not a really terrible high angle case, but it is pretty high. And he looks pretty normal when you just look at him right here. But as this bite opens, this jaw swings back like such, and the further you get it open in here, the further back his jaw looks. It looks like he's got a deficiency in the length of the mandible, whereas he might be perfectly okay with that. So we're going to try to close this down as we go, so you can watch the development of it as we go along here. Alright, this is after the adenoid tissue is removed. I think the next picture shows the adenoid tissue. Let me see. Now here you can see the adenoid tissue in this case. It is darn near close the airway space in there, so we come in and we send him to an ENT guy, and he gets the tonsils and the adenoids out and just clear the airway you can from there. So you can see the void up here where the adenoid tissue was. We've got a big open space in there now. The tonsils are gone too, so he can function right. So we get him chewing and biting on these teeth, and we're also working on with the headgear. We're lowering the vertical by taking some of the teeth out, so we've got a whole bunch of things going to lower the vertical dimension of this guy's face. Now it'll bring the jaw up a little, but he's still got a slight deficiency in the length of the mandible, and we can't grow one. You'd have to do surgery there. Now this is a blown up section right here where we just took a picture of the adenoid tissue itself. I mean, and you can see how large it is and how much it squeezes down on the airway coming through here. So it reduces it quite a bit, and so we're going to come in and have them take that away, as you can see in this next picture. So that's gone. And where the adenoid tissue was, we have a tremendous amount of airway space in there. And so that's going to help this guy with a breathing problem. So now we've come in and we're going to have to come in and take out these teeth right in here. There's 8 teeth, or 4 permanents and 4 deciduous teeth, and you get them out, and you're going to put a lot of force on the 6-year molars here, so you will intrude them to some extent, and that'll help lower the vertical dimension of the face. And we got some crowding problem, and he lost this one first, so these teeth drifted over here. So we'll try to center that up there. I'm going to have to pause this thing or stop.